So let's get off and running then and talk about, first of all, the classification of joints, especially when we talk about the joints that we find in our bodies, because we're going to learn the relationship between how the actual structure of a joint is actually going to relate to its function. So basically, what I'm saying is we're going to learn how anatomy plays a role in the physiology of a joint and how it moves the way it moves, okay? So the examples that we like to talk about when we're talking about joints, otherwise known as articulations, okay, are where you're going to have bones either contact another bone or cartilage or even teeth. So those are where we're going to find our joints. So it's going to be bone on cartilage, or bone and teeth, okay? And so the joint studies arthrology. So if you ever are reading a medical report and it talks about arthropathy, then they're talking about some sort of pathology that's going on in the joint. All right. And so when you see these terms, structure and function, you're going to be thinking anatomy, you're going to be thinking physiology, which is, hey, what we're studying. Oh my gosh, I don't even have the pen. I'm so sorry. You know what you're talking about. I was like, wow, everyone's looking at me and not the screens. That's cool. All right. So when we talk about the actual anatomy of these joints, we're going to break it down. There we go. Okay. So when we talk about the anatomy of these joints, we're going to break it down into a couple of things. All right. So again, dealing with structure. Okay, it is warming up. All right. We have three types of categories or classes when we're dealing with the structural classes. The first is fibrous. So think, fibrous, all right, we're going to be dealing with connective tissue. And in this case, we're going to be dealing with one really strong type of connective tissue, which is dense, regular connective tissue. The same stuff that we find in our tendons, in our ligaments, okay? So it's going to be that dense CT, okay? The next type of class is going to be cartilaginous, easy to figure out, okay? We're going to be seeing bones connected by cartilage. And we see that in our spine, all right? Our intervertebral discs, which is made up of fibrocartilage, right? That's that cartilage that's highly resistant to compressive forces. And then our last one is going to be the synovial joint, okay? And these joints, all right, are going to be a joint with bones articulating that is going to have a capsule around it, all right? But most importantly, it's fluid-filled. All right, we're going to talk about some of the characteristics of this fluid and the functions of this fluid. Most of the joints in our body is synovial, okay? So, but we're going to talk about all the different types. So here, the first part, when we're talking about the classification of joints, we're going to talk about the anatomy. All right, and these are the three classes. Okay, fibrous, cartilaginous, and synovial. All right, so now let's swing into the next compartment here and talk about the functional classes. So we have three of those. Okay, so when we talk about the functional class, we're talking about the physiology. All right. So there's three types with this. The synarthroses, okay, and they are pretty immobile. There's not a lot of movement there. So that means they're either going to be a fibrous type of joint or a cartilaginous type of joint. The next class is amphiarthroses, a little bit more movable, okay? Again, they'll either be fibrous or cartilaginous. And then finally, the diarthroses. These are the ones that have all that movement that we're used to seeing, like in our shoulders, our knees, our hips, right? So these are what we refer to as freely movable. And all of the synovial joints fit into diarthroses. Okay, which means, all right, all synovial joints are fluid-filled capsular joints, and they're freely movable. So they have a decent range of motion, which leads me into talking about mobility versus stability. Okay? So let's talk about range of motion. Okay? So range of motion, just like the term states, that we have a certain range, just like your blood pressure has a certain range of normal values. Your body has a normal range for body temperature values, okay? So we have a range of motion, all right, that joints will exhibit depending on, one, their structural classification, okay? So that will tell us either they're going to be very mobile or not very mobile, if not immobile, okay? So it goes pretty much from no movement to quite a bit of movement. And again, the structure or the anatomy of that joint is going to determine its mobility. And by default, it's going to determine its stability. Because mobility in a joint and stability are related to one another. You have to know that concept, okay? Because it's an inverse relationship, which means, okay, if we have a joint that is very mobile, that has a large or high range of mobility, it is unstable. Okay? So if we increase one, we have to decrease the other. So vice versa, if I were to say a very stable joint is going to be immobile. Okay? We'll have a very low amount of mobility. Okay, so that's that inverse relationship. Okay, so for example, that we see here on the board, skull sutures, the coronal suture, the sagittal suture, the lambdoid suture, what have you. Right? Those joints are fibrous joints. Very, very stable. They're very, very stable. But unfortunately, go ahead and push on them right now. All right? You're not going to get any movement. All right? Very little. Okay, unless they fuse. All right, so that's what we're going to see. All right, pretty much immobile, but very stable. And so flip that to your glenohumeral joint, your shoulder joint. All right, one of the most stable joints in the body. Excuse me, one of the most mobile joints in the body. But unfortunately, you've heard of people getting shoulder dislocations and whatnot, and it's because of its anatomy. All right, being a diarthrotic joint, all right, a synovial joint, all right, it has great range of motion, but it is not stable, okay? So when we deal with the glenohumeral joint, we don't see a lot of stability there. All right, just like this picture is showing you here, we're just showing you that. All right, well, you can't even see it. The range, this is that range. As we get to the top of our little arrow diagram here showing the suture joints, it's saying, all right, that it's stable, but just not a lot of mobility. And then as we move down through the different types of joints, all right, the syndesmoses, that's that joint between the radius and the ulna with the interosseous membrane there. All right, vertebral joints, we start to gain a little bit of mobility, but we now start to sacrifice stability. Hinge joint of the knee, then we get to our glenohumeral joint. Highly mobile, but unfortunately it's not very stable. Okay? So a lot of these joints will range, all right, in their mobility versus stability. Okay, so let's talk about that first classification for structure, and that's the fibrous joints. Okay? And I'm just going to kind of run through some of the general topics here. So fibrous joints, again, these are the joints where the bones are separated, all right, by connective tissue. And it's going to be that dense, regular connective tissue. That connective tissue that's similar to a ligament, that's similar to a tendon. Very strong, all right? There is no joint cavity present. Right? We only see... I shouldn't say we only see it, but we'll see joint cavities with our synovial joints, not with the fibrous joints. So, if you think about it, all right, the sutures of your skull are fibrous joints. Gomphoses, an example of that is your tooth. I'm always trying to get my wife, when she goes to the dentist, to ask her dentist how her gomphoses are, but she won't do it. If I look at her and think that she's some kind of weirdo, then she's already realized that she's married one. Okay? So the gomphoses example is a tooth. All right, sutures we've already seen. And the syndesmoses, that was the example between the radius, all right, and the ulna. How we had those two bones, all right, separated, all right, by that intraosseous membrane, which is a dense regular connective tissue. And it acts as a pivot, okay? Not a lot of movement there, okay? It's really hard to get, all right, a lot of movement between the radius and the ulna. We'll see that also down in the tibia and the fibula, but we haven't checked that out in lab yet, okay? So keep in mind, these types of joints, not a lot of movement, not a lot of movement, okay? So that ranges between immobile to just maybe a little bit of movement there. So what can we say then? If they're not very mobile, what's that say about their stability? Pretty stable. Yeah, they're pretty stable. That's good. We like that. You know, I mean, think about your teeth. Hopefully they're not moving around in your skull. Okay, they should be pretty stable. Okay, same thing with the sutures. Same thing with the radius and the ulna, and the fibula and the tibula. Okay, the next type are the cartilaginous joints. Okay, these are the joints that the bones are going to articulate with cartilage. And we know that there's three types of cartilage: hyaline cartilage, which is the most common, fibrocartilage, and elastic cartilage. Well, elastic cartilage we can throw out. That's not going to be involved when we're talking about articulations. Okay? So we're just going to deal with hyaline cartilage, and we're going to deal with fibrocartilage. Okay? So again, we're missing a joint cavity, and we're still, again, dealing with a joint that is not movable or just slightly mobile. Okay? So, not bad then. Not bad. All right, synchondroses and symphoses, the symphyses, all right, we will see when we're dealing with the pubic symphysis. Remember the pubic symphysis, that little disc there? We just talked about it last lab class, right, where the two os coxa join together, specifically the pubic bone. There's a little disc right there in the front, all right? That is an example of a symphysis, all right, which I like. Synchondroses, ooh, look at this word here. Chondrocyte. Oh, I know, chondrocyte. Dealing with cartilage makes it helpful. The epiphyseal growth plate is actually believed to be a joint when it's in existence. It's kind of crazy. Now, again, though, if you think about it, though, there's not really much movement there. There shouldn't be, okay? But it is considered to be a joint. So the synchondroses, all right, your cartilaginous growth plate is going to be an example, all right, of a cartilaginous joint. All right, let's go to one of the coolest joints in the body, all right, and that's going to be the synovial joint. All right, so synovial joint, you will have a joint cavity involved. Okay, this joint cavity will be found between the bones. All right, these joints are located throughout your body. We're going to go through several different examples and talk about them. Okay, but they fall into the diarthrosis classification, which is the highly movable joint. Okay, and so we have four features here. Okay, we have the articular capsule that surrounds the articulating bones, and it encapsulates the joint space or joint cavity. Then we're going to fill that joint cavity up with some fluid, so we call that the synovial fluid. And if you remember, on the ends of our long bones, okay, we have articular cartilage, which is hyaline. And that articular cartilage is where the two bones will come into contact with one another. And that articular cartilage's job is, one, to reduce friction between the bones as they're sliding, gliding, rotating, twisting, turning on one another, okay? And it also helps to protect the ends of the bone from wear and tear. And they act as a shock absorber, okay? So articular cartilage does a lot. Well, we want to strengthen our joints, so we're going to add some ligaments in there. And these ligaments will help, all right, add stability to the joint. They might cost the joint a little bit of mobility, but that's okay. I'd rather have a joint being more stable so it's not going to dislocate. Well, the nerves, we need something to signal the muscles around the joint to move, but also we're going to learn about what's called proprioceptors. And the proprioceptors are these special receptors that are located throughout the articulations, the joints of your body. And they tell your brain where your body is in space. So, perfect example, the best way I can describe it, and we'll talk about it more, is if I'm standing here in front of you with my eyes closed, all right, and two of you came over and you took my arm, and I'm not doing this, and you took my arm and you just moved it away from my body, okay? And my eyes are closed, so I can't see what's going on. But all these receptors in my glenohumeral joint are shooting information to my central nervous system. And they're telling my central nervous system, all right, exactly where my shoulder is. Like, I know that you would be moving it to the side and not back, because the proprioceptors, the specific receptors, and there's also learned responses and whatnot, are sending that information to my brain. And then if you were to start to move my arm in different positions, I would know exactly where it is, because those proprioceptors are telling my central nervous system where that is exactly, okay? Now, when we're much younger, we don't have as well of a library of knowledge when it comes to that, but through learned movements and whatnot, we'll talk about that when we get into the chapters 13 and 14. We'll learn about how all that works. But the nerves, all right, and the receptors that are part of these nerves are going to give our body all this information, okay? And it helps us to prevent ourselves from getting injured, okay? We found that ankle sprains, for example, once you sprain an ankle, your ankle's never going to be as strong, okay? Just that's how it is. Scar tissue buildup, blah, blah. We can get it up to 99% close, we'll never be 100%. And they found that you're more likely to sprain that ankle, one, because it's not as strong, but two, most often, is that your proprioceptors were damaged and were never retrained how to actually move again. So anyone that's getting into physical therapy, that's going to be stuff that you'll learn. And then obviously blood vessels, okay? We need to nourish the joint, and we need to get rid of the wastes. I tell people it's like dropping off the groceries and picking up the trash. That's what we're doing, okay? And that's what our blood vessels will do. All right, so here's a picture of our synovial joint. Zoom in here and kind of show you all the parts and pieces that I just talked about. All right, so here are the articulating ends of the long bones here, lined with our the articular cartilage here, okay? And there's a joint cavity here that's surrounded by a joint capsule. We'll talk about the different parts of the joint capsule. There's two layers. It seems like there's two layers to everything. The outer layer is the fibrous layer. That's going to be made up of that tense connective tissue. Then the inner layer is going to be made up of the areolar connective tissue. We'll get into that. But we fill this space with that synovial fluid. All right, and then part of our joint capsule way on the outside, we're going to throw some ligaments around it just to make it stronger. Okay? So we'll get into all that fun stuff here. All right, so let's start off. Since we are talking about synovial joints, we have to talk about the capsule. Okay? So we have this double-layered joint capsule. Right? Periosteum has two layers, so why can't our synovial capsule? The outer fibrous layer is going to be made up of that dense connective tissue there. All right? And so this is going to add stability to the joint, prevents us from pulling the bones apart. Does anyone here crack their knuckles? Yeah, I used to all the time. You know the best way to crack your knuckle? Pull them apart. Pull them apart. You'll still get the popping noise if that's what you're after. Why do you crack your knuckles? Feel good? Feels good, right? Most people think it does. For some, it doesn't, right? They've done studies on it, and I've read several of the studies. A lot of it's the placebo effect, but still, sometimes it does help. But what I recommend to people that like to pop their knuckles, just pull. Okay. Well, anyways, when you pull your fingers apart, all right, this fibrous layer is going to engage along with the tendons and the ligaments around that joint. Okay, but this helps prevent dislocations. The inner layer is the synovial membrane. It's a loose connective tissue, areolar connective tissue, and its job is going to be to produce the synovial fluid. Synovial fluid does a lot. We'll talk about that in a moment here. All right, but now pay attention to this second point here. Covers the internal joint surfaces not covered by the cartilage. All right. Well, why doesn't it cover the cartilage? Why doesn't it cover the articular or hyaline cartilage in the joint? It's because it would hurt. Okay? You get that areolar connective tissue caught in between those two bones. As they're turning and twisting and pressing against one another, you would damage the tissue. So it makes sense to not have it cover the cartilage, the articular cartilage. If you look at the word articular, it means to connect with. All right, it's making contact. So we don't want to put, all right, it's like putting a rug down that you don't want to get dirty in front of your door when people are coming in and out. You're going to walk on it, right? So if you want it to remain dirty, if you want it to remain clean, don't put it there. So if we don't want to damage the areolar connective tissue that produces our synovial fluid, we're not going to put it in an area where it could get damaged, all right, where there's high traffic, where there's a lot of action going on. Okay, so the articular cartilage, we've talked about this already back in chapter 7, okay? It's hyaline cartilage, right? But when we're dealing with the cartilage on a joint surface, we call it articular cartilage. And it has the functions of friction reduction, all right, shock absorption, all right, and it's also going to help to cover the ends of the long bones there to prevent damage to those bones, okay? It's going to prevent damage to those long bones. And I mentioned this before, I believe, in this class. Sometimes everything starts to run together. But, and you probably talked to relatives or some older friends that are having knee problems or even arthritis in their hands. And they'll say that their doctor says that there's no more cartilage in my knees. There's no more cartilage in this joint here. Well, that's a problem, because if there's no cartilage there, that means you're bone on bone. And when you're bone on bone, you're going to start, if you ever take two rocks are pretty tough, right? They're pretty hard. You take two rocks, if you grind them together long enough, and you look down at the area that you were grinding those rocks together, you're going to see dust there or parts of the rock. Well, hey, guess what? That happens to your bones when that cartilage isn't there. They just start to grind on one another. It wears it away, okay? So this articular cartilage is going to help to prevent that damage from occurring, okay? Well, guess what? And you need to make a note of this. It does not have a perichondrium. Well, hey, wait, Dr. Kaz, you told me that articular cartilage does have perichondrium. That and elastic cartilage. That fibrocartilage was the only cartilage that didn't have perichondrium. There's always exceptions to the rule. This is one of them. Okay? There's not going to be perichondrium there. Because again, this is where the two bones are going to be rubbing against one another. We would be constantly damaging that perichondrium, and that would be a problem. Okay? So if we don't want it to be a problem, we get rid of it. We don't put it there. All right? Now, we already know that mature cartilage is avascular, so that's a no-brainer. We know that. Okay? So articular cartilage is no different. Avascular, mature cartilage is avascular. Okay? Keep that in your brain. Don't ever forget that. Okay, so the next part of a synovial joint is the cavity itself. Okay? So you ever wonder why when you do go to pop your knuckles, right? When you go to pop your knuckle again right after you've done it, how come it doesn't pop? Does anyone know why? Does anyone know what the popping noise is? It's gas, that's right. I tell patients all the time, if you're popping, you're gassy. Okay? So the gas is actually nitrogen gas. Okay? And the nitrogen gas is dissolved into the synovial fluid. So when you go to pop the joint, you are creating a physical state change. You're causing that gas to come out of the solution that it's dissolved into. It goes into its gaseous form momentarily. And so that actual process causes the popping noise. But it takes like 20 minutes to get another pop out of it because you got to get the gas to dissolve back into the solution. So that's what happens. You just learned a little chemistry right there. All right. So our synovial fluid is going to be this beautiful, beautiful viscous. What does viscous mean? Y'all remember? Like thick. Syrup is viscousy. It's viscous. All right. I'm trying to think what else. Glue is viscous. All right. Water, not so much. Motor oil. Okay. So this synovial fluid is going to have a viscous, oily type of consistency to it, which is good. Because of that, it helps to act as a shock absorber, okay, while lubricating the joint. And it's wonderful because it helps to lubricate the articular cartilage there. So it supplies the actual motion and movement, and this is why it's so very important in folks that have degenerating conditions of their joints, that they try to stay as active as possible. Activity and movement creates, we know this already, well, we know what this process is, I should say, diffusion. Diffusion is that passive process of moving substrates from an area of high concentration to low concentration. Well, movement facilitates this. And our cartilage is avascular. We just saw it on the previous slide. So it doesn't have blood to get its nutrients from. So we need to promote diffusion. And so by doing so, we will just create movement. And when we have movement in a joint, it facilitates diffusion, and we can get substances from the synovial fluid to enter into the articular cartilage. And at the same time, we can get wastes coming out of the articular cartilage into the synovial fluid. We filter it out and get rid of it. Okay? So it's hugely important that it's present because it helps to lubricate that cartilage and keeps it healthy. At the same time, it nourishes it, gets rid of the wastes. Okay? And then shock absorber. Cool? Cool again? All right. So, staying with synovial joints, I want to talk to you about some of the movements here that occur in these synovial joints, right? And so a lot of it has to do with the shape of the joint surface. Right? So if you look at the terms here up on the board, we're talking about the classification of just some of these movements. Uniaxial is one axis. Right? Obviously biaxial is two, and then multi is going to be many. Okay? So when we're talking about these classifications for movement, we're going to deal with a plane or an axis. Well, we learned all the planes earlier. Okay? Remember those, the coronal plane, otherwise known as the frontal plane, and the transverse and all that. Okay? So don't forget those, okay? But now we're going to talk about the axes, and this is going to be, you have the X and Y axis, this is going back to math. So the horizontal one is the X axis, the vertical one is the Y axis. So like saying going side to side, that's the X axis. Going up and down, that's the Y axis. Which one am I missing? The Z axis. And I draw it as a dotted line because it's coming straight out at us. Okay? So you have those three axes. Okay, the X, the Y, and the Z axis. So that's what we're talking about when these joints move around a certain axis or plane. Okay, so keep that in mind. So biaxial is going to be two planes or two axes, and then multi-axis is going to be many planes or many axes. Okay? So, let's check out, all right, here, all these different classifications of our synovial joints. At the top, the plane joints are going to be the least mobile, all right, and then the most mobile will be here at the bottom. Okay, so plane joints are the least mobile type of synovial joint. Ball and socket joints are the most mobile. Well, doesn't that make sense? For example, your shoulder, your glenohumeral joint is a ball and socket joint. That's pretty mobile. Your hip joint, let me rephrase that. Your femoral acetabular joint, that's where your femur, which is the bone in your thigh, connects to your os coxa at the acetabulum. That's a ball and socket joint. Okay? What's a plane joint? Okay, I'll give you an example of a plane joint. That's my job. Plane joint is the joint in between two of your carpal bones. Okay, where they just kind of glide past one another. That's going to be a plane joint. All right, so that will be the least mobile. There's still some movement there, though. If you think about it, your wrist is pretty movable. That's because of all both the rows there and all the articulations that are going on. But a plane joint is when we're going to see, all right, that movement there going back and forth. All right, so let's further classify these. Okay, so I just talked about, all right, the plane joint. The two articulating surfaces are going to be flat. All right, it is uniaxial or uniplanar, which means it's going to have a gliding movement or motion in one single plane. So either the frontal plane, the sagittal plane, or the transverse plane. It can only go in one way, one direction. So it's just basically going to slide back and forth, glide back and forth. That's a plane joint. Hinge joint, I think we all can anyone tell me a hinge joint in your body? I heard you. What did you say? That's a good one. Yeah. Your knee, yeah. Your elbow, hinge joints. Okay, like a door hinge. Okay, swinging open and close. Okay, so in the hinge joint, we're dealing with a convex surface, and a convex surface is like a curved surface like this. Okay, within a concave depression. So that example that you gave with the jaw. All right, the condylar process there on the mandible, all right, and then it sits in the mandibular fossa on the temporal bone. That's our concave depression. Okay, great example. All right, and then we have our pivot joints. Okay, so we're going to deal with, all right, we have a bone that has a rounded surface like this, and then it's going to fit into some sort of ligament ring. You probably don't remember this because I only mentioned it once. Does anyone, well, I'll just tell you. A pivot joint is C1 on C2. Remember the dens, all right, or the odontoid process and how it sat right behind C1, the atlas? And there was that ligament that held it against there, the transverse ligament. And that's, when it moves, you shake your head, no. All right, that's an example, all right, of a pivot joint. Okay, it's going to rotate on its longitudinal axis there. And in that case, that longitudinal axis is the y-axis. Okay? Good so far. All right, condylar joints. All right, now if you see here, we're starting to get into joints that can move in more than one plane or one axis here. All right? So we can see with the condylar joint, the saddle joint, and the ball and socket joint. All right, anything that has a condyle, you name a condyle, all right, then we're going to see, all right, that movement. Occipital condyles on C1. Mainly it does yes, but it also does a little bit of lateral flexion side to side. So it has more than one axis there, all right? It can move around. But we're going to deal with an oval or convex surface, all right, which again is going to articulate with a concave surface. So one surface goes like this, all right, and then the other one goes like this concave. I always think you walk into a cave. Here's the cave. You walk into the cave, okay? All right, saddle joint. We're going to, again, think of putting two saddles together. And I wish I could draw, but I can't. All right, but when we put both the convex and concave surfaces together, it'll resemble a saddle, like a horse saddle, and your thumb is a perfect example. Okay, where the phalange and the metacarpal, all right, meet with one another, that is a saddle joint. And you notice that your thumb has several different movements. All right, so it can move in several different directions. Then finally, our ball and socket. This is the multi-axial axial one, okay? This is the most mobile type of joint that you can have in your body, okay? And it's a ball and cup, okay? So you have this cup-like process here, or not process, excuse me, depression, and then the ball sits right in there, all right, with the bone coming out of that. And it swivels around, moves around, all right? And we'll break this down in more detail here when we talk about the movements, okay? So the ball and socket joint is the most movable type of joint in our bodies. Okay, so let's talk about, all right, now we're going to start to talk about, when I say the fun stuff, not to think that the other stuff isn't fun, but now we're going to talk about movements. In case you're ever wondering, you know, some of us know the definitions for like flexion, extension, you'll hear terms like rotation, lateral flexion. Now we're going to actually see and understand some of these things. So the first type of motion we're going to talk about is gliding, okay? You heard me talk about this. This happens with a plane joint, all right? You have two flat surfaces that are going to slide back and forth on one another or side to side, okay? So again, this is only going to occur, all right, in plane joints, which means it's only going to occur in one plane of motion, all right? So this is what we see in our wrist, and we haven't talked about the tarsal bones, but the tarsal bones are the bones of your feet. Or I should say, the bones of your feet, not including your toes and the metatarsals. So they make up like the back portion of your foot. Your heel, right, where your arches are located. Okay, those are the tarsal bones. Okay, and so the joints in between those bones, right, they just glide back and forth on one another. Okay? All right. The next type of motion is angular motion. Now we're going to get into the fun stuff because we're going to see all these different types of movements here. And you can see them up here on the board here. Flexion, extension, hyperextension, lateral flexion, abduction or abduction, and AD or adduction and circumduction. So now we're going to talk about all these different movements, all right? So when you put your arm in this position, you're flexing your arm. Or if you put your arm in this other type of position, you're abducting your arm. So we're going to start to talk about that. So when we're dealing with angular motion, this is the mathematical symbol for angle is this. Okay? It should look better. There we go. It's better. Okay? So what we're going to do is we're going to either increase or decrease the angle between our two bones. That's simple. Okay? We're going to increase it or decrease it. So we're going to go through each of these individually here. So by the end of class, you will have a commanding understanding of all these different movements here. Okay? So flexion and extension. Hyperextension, to be honest with you, you know, when I talk about hyperextension, or prior to teaching this class, when I talked about hyperextension, it was usually for an injury. You ever have someone, oh, I hyperextended my elbow or hyperextended my knee if they're doing some sort of sport. That's when you would really hear about hyperextension. I'm going to show you the physiological definition for it. All right, lateral flexion, abduction. A lot of times when I pronounce abduction and adduction, you'll hear me say abduction. So you can understand, because sometimes I talk too fast. And then adduction. And then finally circumduction. Okay, so flexion, what is it? Okay. Well, first of all, we're going to move in the anterior and posterior plane. So what's in front of you and what's behind you. Okay. So when we bring the bones close together or decrease the angle, the example here is bending your finger. How about flexing your elbow? All right, when you flex your elbow, you're bringing your radius and ulna. All right, let's just use one of the forearm bones. You're going to bring your radius closer to your humerus. Right? Isn't that what I'm doing? As I bend my elbow, I just brought my radius closer to my humerus. All right, so that's flexion. Okay, so I'm bringing the bones closer together, just like with your finger. Okay, if we're going to bend our finger here between the proximal phalange and the middle phalange, all right, when I bend it, like, hey, come here, you come here. Right, when I do that, then I'm actually bringing those two bones closer to one another. Okay? So extension, same thing. It's going to move in the anterior posterior plane, but it's going to go in the opposite direction of flexion, which means we're going to increase the angle. We're going to pull the bones away from each other. Okay? Okay, so after you make a fist, you straighten your fingers out to shake somebody's hand, or if I just bent my elbow, now I'm going to straighten my elbow out. Okay? And I've just moved my radius away from my ulna, my radius away from my humerus. Okay? So that's going to be extension. I'm going to come back to these slides here. Let me just pull up this one here so you can see. Pictures are awesome. Okay, so this guy here, we'll start off, he's looking straight ahead. When he bends his head forward, okay, he's flexed his neck. He's looked down towards the ground. So he's bringing his vertebra closer to his sternum. Now, when he goes to looking straight ahead again, all right, he's going into extension because now he's moved his vertebrae away from his sternum. Okay, you're going to be moving the bones away from each other for extension, and you're going to be bringing them closer together for flexion. Okay? Yeah, that's yeah, you know, and it's funny because a lot of the times when I tell people to extend their neck, if I'm doing a range of motion on their neck, when I have them look up at the ceiling, that to me is more of extension. But according to this definition here, right, depends on it, because in certain textbooks there's a different, especially in PT, you know, when they talk about extension and flexion of the head and neck, they have a little bit of a different definition. But we're going to go with what the book is saying here, okay? Because when we deal with hyperextension, now we're going to extend the joint more than 180 degrees. Now, when hyperextension is used to describe an injury, it's because if you flex it, or excuse me, if you extend it more than 180 degrees, all right, and it's due to an injury, it's because that joint is not capable of going past 180 degrees and it causes injury, okay? So when we talk about hyperextension, you can do it with the wrist or you can do it with the neck. If you look up towards the ceiling, you're hyperextending the neck. You're going to go past 180 degrees, depending on how much flexibility you have in your neck. Or with your wrist. If I put my wrist, like I'm waving to you folks, and then if I bring the palm of my wrist down towards my forearm, that's flexion. When I bring it back to this position here, that's extension. But if I bring it back this way, if I bring the backs of my fingers back towards my forearm, that's considered hyperextension. Okay? All right, when we deal with lateral flexion, we're going to be talking about the trunk mostly. All right, you can still have lateral flexion with the head also, okay? All right, but what we're going to do is we're going to move, all right, through the coronal plane, side to side, okay? Side to side. So when we talk about moving things through the with lateral flexion, all right, in the spine, all right, we're going to talk about the cervical and thoracic region. You don't get a lot of lateral flexion in your thoracic spine. Does anyone know why? Moving side to side in the thoracic? Because your ribs are there and they bang into each other, okay? So they prevent you. Your ribs will, you have a small amount of lateral flexion. You do in the thoracic spine, but for our purposes, it's negligible. We're not going to really include that. All right, but we're going to talk about the areas where there's no ribs, so that'll be the cervical and lumbar region. So an easy way to do lateral flexion for the cervical region is I say, hey, listen, I want you to take your right ear and try to touch your right shoulder with it. Look straight ahead, take your right ear and touch it to your right shoulder. That's lateral flexion. All right, now take your left ear and try to touch your left shoulder with it. That's lateral flexion. For the lumbar spine, stand up straight with your hands to your side, slide your right hand down to your knee. Lateral flexion. Okay, same thing on the left side. Down to the knee, lateral flexion. All right, the coronal plane, remember the coronal plane will cut you into anterior and posterior portions. So it goes side to side. So I'm moving in the coronal plane. Another way to remember that, coronal suture. Coronal suture. Okay? All right. I'll show you a quick picture here. Okay, so here's the flexion and extension of the elbow. Okay, here's the wrist. All right, start in the neutral position. All right, bring your palm down towards your forearm. Okay, that's flexion. Returning it from that position back into the neutral position, that's extension because we're moving the bones away. Okay, this angle is small. Okay, and then when we go back to the neutral position from flexion, all right, that's less than 180 degrees. Now, if you try to touch the back of your hand to your forearm, that's greater than 180 degrees. Kind of see that? You know, 180 degrees is that. That's 180 degrees. I can't even write it. All right, and in a right angle, we all know what a right angle is. How many degrees is a right angle? 90, that's right. 90 degrees. Okay. Quick math review, or geometry. All right, here's extension and flexion of the knee. So if you're standing straight up on both feet, and I ask you, okay, I want you to bend your right leg, you are flexing the knee. This is actually the left, so bend the left leg. All right, you are flexing the knee. And then when I say, okay, you flexed your knee, then I say, okay, go ahead and straighten your leg out. You have extended your knee. Here's that lateral flexion. Okay, stand here facing forward, your arms to your side. Now take your left hand and slide it down to your knee. You're leaning to the left side. That's left lateral flexion. Okay. Okay. All right, a couple new terms that you may have not heard about before, still dealing with angular motion. All right, we have the term AB or abduction. What happens if I'm driving along in a van and you're walking down the street and I pull up next to you and I have a mask over my head? It's going to sound really weird, but go with it. All right, and I slide the van door open and I jump out and I throw you in the van and I drive off. Boom! And someone saw me do that to you. What is one of the terms that they might say to describe what I did to you other than kidnapping you? I just abducted you. Okay? So when you abduct something, you're going to take it away. Okay? So in this case, when we talk about abduction, we're going to take the body part away from the midline of our body. Well, what's a good anatomical marker for the midline of our body? Our axial skeleton, our spine, the skull. Okay? So that's what we're going to use, or our belly button. Okay? That's going to be our midline. So essentially, the lateral movement, all right, we're going to take that body part and move it away from our axial skeleton or our midline there. So that's going to be me standing here facing you. And when I bring my arms, they're by my side, and if I bring them out away from me, I am AB or abducting my arms. I am moving them away from my spine. Okay? Out and away. Same thing with my thigh. All right, bring your leg away from your midline. Okay? So, if we now decide, all right, I'm going to bring my arms back down and put them back to my sides, that's adduction. I am adding them back to my body. I am bringing them toward my midline there. That's a medial movement. Okay? So I move my arms away from my body. Now I'm going to bring my hands back against my sides. All right? Or my foot is away from, my leg is outstretched away from me. Now I'm going to bring it back. So here's a couple of examples for abduction and adduction. Okay, here you see the lady, she moved her arm up and away. She's abducting it, moving it away from the midline, because here is our midline, right here. Okay, then when she brings her arm back towards her side, she's added it. Medial movement, bringing it back to the midline. You guys cool with that? Cool, cool, not too bad? All right, now the hand one's a little bit different. Okay, well, no, not the hand one, so I'm jumping ahead here. All right, this is in the anatomical position here. So if your palms are facing forward, all right, if I lean my thumb, I try to bring my thumb and touch it to my forearm, all right, I'm bringing it away from my midline, right? Because my midline is still my vertebrae. So even though I'm in the anatomical position and I do this, and I bring my hands away, you guys probably can't see. If I'm doing this, all right, my midline is here, I'm moving it away from the midline, that's abduction. When I do this, when I bring it towards my hips, that's adduction, okay? There's other terms for that, okay? Ulnar deviation, radial deviation, but we're not going to learn those terms. All right, and then you can see here, I think you get the point for the hip, all right? Abduction, moving the leg away, and then bringing your leg back down, all right? That is adduction. Fingers are a little bit different, okay, when you're spreading your fingers open. In this situation, we have a new midline. Our midline is the third digit, okay? So when I spread my fingers out, they're moving away from the third finger, okay? So they are abducting away. They're moving away from the midline. When I now they're spread out. Now I'm going to close them. I'm going to add them to the third finger. That's adduction, okay? So we change our point of reference. We're no longer going to be using the axial skeleton or the midline as our midline. We're going to use the third finger. Okay, and then we got circumduction. And the example that I like to talk about is drawing a circle on the blackboard. All right, or you can make arm circles. If you want to go and warm up for something, if you're going to play baseball and be the pitcher, and you want to warm up. All right, the proximal portion of whatever joint that you're using is going to stay, all right, in a relatively stationary position. It's not going to move a lot. Meanwhile, the distal end, all right, is going to move in a cone-like fashion. Okay, same thing. So you can really, I mean, ball and socket joints are great for that. Okay, when we deal with circumduction, because their range of motion can handle that, it moves in a couple different planes. All right, so that's circumduction. You're just kind of making a cone. Okay. All right, that was angular motion. Now we're going to talk about rotational motion. Okay, so all those terms that we just discussed are what we call angular motion. All right, so in this situation, when we get to rotational, just like the term says, we're going to rotate along whatever the bone's longitudinal axis is going to be. Okay, so whatever that bone's longitudinal axis is going to be, we're going to pivot or rotate around that axis there. So we have lateral rotation, medial rotation, pronation, and supination. Okay? So for lateral rotation, you know, we are going to actually take, all right, the anterior surface, and we're going to move it laterally. So what I tell folks to think of is bend your elbows at 90 degrees and put your fists right out in front of you, like this. All right? If I'm going to do lateral rotation, okay, now the anterior surface of the bone that I'm going to be dealing with is going to be my humerus, all right, my biceps muscle. So that anterior surface, I want it to point laterally. I want to go that way. So I'm just going to move my fists out. Okay, you see how it's, if I had white tape, I'd put it on here, right? But it goes out. All right, so the anterior surface of that bone will move laterally, okay? So the opposite is going to be medial rotation. Okay, so elbows bent again, and then I'm going to immediately rotate. I'm going to turn my fists in. That's going to make that anterior surface, my biceps muscle on the front of the humerus there, it's going to turn in. That's going to be medial rotation. Okay? Pronation, supination, we saw that before. Okay? When you are in the anatomical position, your hands are in the supinated position. How I remember that is, take both your hands, bring it together. Imagine that you're holding soup in your hands. You're making a bowl, okay? So when I want to pronate, I'm going to pour it out. Pronate, I'm going to pour that soup out. So I'm just going to turn my palms down, okay? That's what we're going to see here. So when we talk about pronation, we get medial rotation of that forearm towards the posterior portion. See, when we're supinated, All right, the palm and the hand are facing anteriorly. So in the anatomical position, I'm supinated. My palms are facing forward. All right, my forearms are facing forward. If I want to go into pronated position, I just turn my palms and forearms back. My palms are now facing posteriorly, and the anterior surface of my forearms are facing posteriorly. Okay? So that's going to be pronation. Let's show you a picture. All right, so this first example here, you're seeing this lady, all right, swiveling her head, turning it from side to side. All right, her rotational axis is going to be here. All right, so if she turns her head to the right, that's right rotation. If she turns her head to the left, that's left rotation. All right, now when we're talking about the joints here, the forearms, here's the anterior surface, okay, it's pointing out. Here's the anterior surface on medial rotation, it's pointing in. All right, and the same thing with your hip. Okay, if you want to do the hip, think of the anterior surface of your thigh. All right, and so what I tell folks to do is put your foot out straight in front of you. All right, and my thigh is facing forward. Now turn your foot in. When I turn my foot in, the front of my thigh turns in. That's medial rotation. All right, now put it back in the neutral position. Turn your toes out. The anterior surface of my thigh turns out. That's lateral rotation. You can use the foot to help with that, whatever you want to use as your reference point. Okay? And that's what we're seeing here. Okay? This person's turning their foot out. That's lateral rotation. The lateral surface of the thigh will turn out. All right, for medial rotation, the lateral, not the lateral surface, excuse me, the anterior surface will turn in. All right, and then you can see here, pronation, supination. Supination, palms forward. Here's the anterior surface of the forearm. Okay, it's facing forward, as is the palm. Now you turn it back. Yeah, to the last slide. Yep, you got it. And then when they turn their palm backwards, you can't see the anterior surface or the palm because that's facing posteriorly, and that's pronation. Yep, let me go back. There you go. All right, so those are going to be rotational motions. We're going to have a couple special motions here too in a second. All right, we're almost done. All right, so keep in mind, all right, this is rotational motion. All those other movements that we talked about were angular motions. All right, this is rotational. So we're going to have a pivot point, and whatever that pivot point is going to be, all right, the bone is going to rotate it along that. That's going to be its longitudinal axis there. You got it. Okay, so now we got special movements, of course. Let's add in a few, okay? So we got depression and elevation. Okay, no problem. So here, when we're talking about depression, we're going to, whatever our reference structure is going to move inferiorly, okay? Mandible, when you open your mouth, your jaw drops. It goes down, okay? Elevation, okay? Where you're going to move, whatever our reference structure is going to move superiorly, okay? When you close your mouth, your mandible elevates and it moves up, okay? Shoulders, think about it when you shrug your shoulders. If I bring my shoulders up to my ears, I am elevating them, right? When you, I don't know, so you're elevating your shoulders. When I drop my shoulders back down, that's depression, okay? So depression is going down, and think about it. All right, when you're sad and depressed, you're feeling low. Well, inferior, you're going inferiorly, you're going downwards, okay? Elevation, you're elevated, you're like, yeah, I'm going higher. I'm going to take the elevator up to the top of the building, all right? That's moving into superior motion, okay? So there's depression versus elevation. Okay, dorsiflexion and plantar flexion. I'm going to start with plantar flexion first, because for any of you who've ever played basketball, that's what I always think about. If you play basketball, your coach will say, plant your foot and jump. Okay? Because that's the next thing that's going to happen. When they say plant, you're planting, and then when you jump, you're pushing off the toes, the balls of your feet. Okay? So that's what I think of. So when we're talking about plantar flexion, the example they use is a ballerina on their tiptoes, whatever. All right? But you're planting your foot, and then you're pushing off your toes. So you're planting and pushing off the balls of your feet to jump, okay? That's plantar flexion. We'll talk about these joints here, well, if we have time when we're doing, golly, what's wrong with my brain? When we do lab, all right, the talocrural joint is actually just your ankle joint, okay? All right, so the dorsum, what the heck is the dorsum? The dorsum is the top of your foot. That's this thing right here, okay? So when we talk about plantar flexion, all right, the dorsum is going to be pointed downwards, okay? Remember the dorsal fin on a shark is on the back of the shark? All right, well, the top of your foot is considered to be the dorsal portion of your foot. All right, dorsiflexion, okay? Now our ankle joint, we're going to bring the dorsum of our foot, the top of your foot, towards your shin, okay? So when they talk about digging your heels in, if you've ever had somebody, and this is a way to test to see if you have a nerve issue, is I'll have the patient get on their toes and walk just on their toes. That's plantar flexion, all right? And I'm testing their calf muscles. Now if I want to test their shin muscles, okay, then I'll ask them, okay, go ahead and walk on your toes. So when I'm walking on my when I'm walking on my heels, when I'm walking on the heels, I have to lift my toes off the floor. That's dorsiflexion, okay? So dorsiflexion, you're going to be trying to bring your toes or the top of your foot up against your shin. Plantar flexion is when you're pointing your toes down. All right, eversion and inversion. The most common type of ankle sprain is an inversion sprain, and that's because you turn the inside of your foot, the bottom of your foot, inwards, okay? So basically, when we talk about eversion and inversion, we use the sole at the bottom of your foot as our reference point. So if you want to put your foot into eversion, turn your sole out, okay? It's hard to do. We don't really have very good eversion, all right? When I say we, I'm speaking for me, okay? And then inversion, we're going to turn the sole in, right, or medially. So you can see here, the bottom of the foot is being turned inwards. And again, you'd have to talk to a physical therapist, but I would say, in my experience, 70 to 80% of all ankle sprains are inverted ankle sprains. Less than 20 are eversion. All right, inversion versus eversion, protraction and retraction. Okay, especially if you've had to go to the dentist, you've probably done these maneuvers here. Okay, so if you need to push your jaw forward or have it move anteriorly, you are protracting it, pushing it forward. Push, protract, both begin with P. Okay, then retraction is moving it backwards or posteriorly. Okay, you're going to pull your jaw inwards towards, we had to do this at the Citadel when I was there. They called it the brace. You had to assume this position where you stood straight up, rolled your shoulders back, pulled your chin and head as far back as you possibly could. I used to have a nice cervical lordosis. Now my neck looks like this. That's what happens when you walk around for a year like that. So I lost my curvature. I'm in phase 1 of spinal degeneration. Are you happy? Just kidding. Okay. Are you happy, Citadel? My alma mater? Look what they did to me. All right. Let's just finish up and talk about just a couple of pathologies or clinical issues that you can see. All right. So you see listed up there 3 conditions: arthritis, gouty arthritis, osteoarthritis, rheumatoid arthritis. I should have put psoriatic arthritis up there. All right. But it's not. Okay, so arthritis is going to be, okay, it's a grouping of conditions or pathologies that deal with joints. Arthro, okay, remember? Arthropathy, arthrology is the study of joints. Well, arthritis is, and any type of itis is an irritation. So arthritis is a joint irritation. It's inflammatory. What does that mean? It means there's tissue damage done. Anytime you have the inflammatory response, there's damaged tissue, which means swelling. which means if it's chronic and left alone for a long period of time, you're going to get degeneration. And degeneration is often irreversible, so that kind of sucks. But some of the symptoms that are going to be associated with arthritis is going to be obviously pain and swelling because of the inflammation. And then stiffness will result because you reduce the amount of movement in that joint because of the swelling, and it's compromised the muscle function and the nervous function. Okay, so swelling, pain, and stiffness are going to be some of the symptoms that we'll see with arthritis. Now, gouty arthritis, all right, has to do with uric acid crystals formation. Okay, so basically, uric acid, all right, is a product that gets formed in your joints, in some of your cells, through the process of making urea. It involves nitrogen. Okay, so anyways, these crystals precipitate out of the synovial fluid because there's high amounts of nitrogen in the synovial fluid, and it forms these crystals. Would you like to have rocks in your socks when you're walking around in your sneakers? No, heck no. Well, these crystals, when they precipitate out, they get stuck in the joint spaces. Very painful. And so you're trying to move the joint, and it hurts like a son of a gun. You'll see it in middle-aged to older males, people that have a bad diet. They get dehydrated. That's the number one thing I tell my patients with gout. I said, listen, if anybody ever comes to you, does anyone here know anybody that has gout? Do you know one of the things they say when they have a gout attack? They said it's so. Yeah. Does he get a good night's sleep?
No.
No. Here's the thing. Most times it affects the big toe. It's the weirdest thing, but it precipitates out in the big toe for whatever reason, and it's so painful that the patient will complain that they can't even put their bed sheet on their toe. They can't even put a little bit of a bed sheet on their toe. So the easiest way to prevent it from happening is to stay hydrated, because then those uric acid crystals won't precipitate out. Don't drink Coke. Don't drink coffee. Stay away from processed meats like salami, all that stuff. Those few things and some of the processed foods, they can avoid gouty arthritic attacks. I can't talk. Osteoarthritis. Well, hey, what's osteo mean? Bone. Okay. So osteoarthritis is going to be, when we're going to be dealing with, obviously, well, if we're dealing with joints, we're going to be dealing with bones, okay? But this type of arthritis, we call it OA for short, right, is the degenerative joint arthritis that you see in older people. I didn't want to say old folks, okay, because it can happen in people in their 40s and 50s, okay? So this is the type where you maybe talk to grandpa or grandma and they're talking about, oh, my fingers hurt all the time, or my back hurts or whatever, and my doctor told me I have arthritis. This is the arthritis that they're talking about. All right, it starts off, they've worn down their articular cartilage. Well, there we go. If the articular cartilage goes, then the bones are going to start grinding on each other. And when bones start grinding on each other, I already told you what happens. You're going to get inflammation. And they just don't do anything about it. And then eventually it causes such a bad scenario, they might have to get a knee replacement or a hip replacement or such and such replacement. Okay? So we'll see it a lot in the weight-bearing joints, hips and knees a lot, even in the back. Shoulders, you'll see it. It's not going to be as bad. All right? Fingers, knuckles, all right? People that work with their hands quite a bit. It's a wear and tear. Osteoarthritis is a wear and tear arthritis. All right? If you did a lot of work with your hands, you're going to get it. All right? Rheumatoid arthritis. This one's all over the place. I hate to say it, I apologize, ladies, but it's more often in women because women are more prone to autoimmune conditions. All right? And so what happens is the synovial membrane will become inflamed. And then it'll form this thing that's called a pannus, P-A-N-N-U-S. And it's when that synovial membrane gets so inflamed, and it's then creates inflammation. And that inflammation creates swelling. And then over time, we'll start to get that degeneration here, because it is a degenerative form of arthritis here. You don't see it too often. You'll see it in the back, all right, some of the larger joints. But if you see it in a young person, because it can happen at a young age, teenagers, and they'll start to complain of neck pain. And that's called juvenile rheumatoid arthritis. So if you have somebody and they're young, they're a teenager, like, my neck's bothering me, they've done no trauma, nothing, get them an x-ray and see. And then you can do what they call an RA factor, which is a marker that they can take from your blood to see if you have the trait for rheumatoid arthritis. It's just one of those things. And it's painful. There's drugs that will help with it, all right? But again, it's an autoimmune disorder, and it's going to affect the synovial membranes. Well, guess what? Most of the joints in your body are synovial joints. So this can be widespread. It can be all over the place, okay? All right, any questions for me? We did it. We knocked out Chapter 9. You now have all the material for your test. And shame on me, I didn't do one thing real quick. Well, that's pulling up. No! All right, well, that's great. Just a reminder, okay, we're wrapping up week 6 here. So in lab, we will finish up the appendicular skeleton. That means next week on Monday and Tuesday, you've got your lecture exam 2 on chapters 6, 7, and 9. And then on Tuesday and Wednesday, that's the 23rd and the 24th, you have to take your second lab exam, which is chapter 8. Okay, that's on Tuesday and Wednesday of next week. All right, so basically Monday, Tuesday, and Wednesday, you have to take 2 tests, all right, during that time. And then let me just remind you of your assignments for this weekend. All right, Learn Smarts, chapter 7 and 9, quizzes, chapter 7 and 9. Those are due on Sunday. Okay, so both of those are due. And thank you, Google Chrome, I hate you. Okay, so, sorry, Google people. Let's take a break. Folks at home, I'll just have to review that with them when we're done. Okay? God.